Hey, welcome to my podcast. My name is Dr. Brendan McCarthy. I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you so much for tuning in to the podcast. Glad you're here. So, there's been a lot going on, and I got a lot to share. Today, I want to talk about some of the comments you've brought up, and we're still having a dialogue around hormone replacement therapy with women and the need to run labs. And this all stemmed from a previous series I was doing on the idea of testosterone replacement therapy in women and labs. And then, comments kept coming in about some people arguing that women should not need labs, and other people arguing that how can you practice medicine without labs? And then people arguing like, why are you using hormones? You get a lot of stuff online. And I try and navigate it. If you like what I'm doing, please subscribe. If you like this series, this episode here, please like it. And if you think this will help someone, please share it. I got that out of the way. All right, now let's get into the material. I try and do every episode, I think about someone who inspired me and who I think this would be helpful for, and just someone who I feel connected with on the subject. And right now I'm thinking about a woman, and I was young. I was 24. These are during my years of wandering. And I met this woman, and her and her husband had just moved to the town I lived in. This woman had just had a couple of years earlier, surgical menopause. And she had her uterus removed due to fibroids, but they also removed her ovaries. And I remember this. It sits with me to this day. This is 30 years ago. I remember her, 30-something years ago. Geez, over 30 years ago. And she was so upset and sad because of this surgical menopause. She did not know what was going to happen to her. She just thought that they would just stop this problem she was having with her fibroids, and she thought her health would be returned to her. And she was, late 40s, early 50s when it happened. I met her at a very early 50s. And, she'd gained 60 pounds, and she aged dramatically. She showed me pictures. Her husband was there. I said, this. And I remember that sitting with me, that something like that could happen. And that memory still sits with me today because she didn't know that was going to happen to her, or it was going to be taken from her. And it's tragic because it was her life. She's just a beautiful person, beautiful soul. I think of people like her when I do this work, because you deserve to know. And then once you know, you can make an educated decision. This is not me saying she should not have had the hysterectomy, right? It's not me saying that. This is me saying that if that's going to happen, we should know what happens secondary to that, what comes after. And is there something we do to help her? So important, such a good topic to discuss. And it keys into today very specifically. So there's been some comments on one of my reels stating, that they go to their doctors and their physicians will just prescribe them straight up estrogen without really spending the time to run her labs. And, I have opinions of this because and I said this before, it should be repeated. This is not benign work that we do. Otherwise, it'd be over the counter. There is risk in all things we do. And on top of that, I'm accountable to my patients as a physician for what I do with them. There's an important distinction between me prescribing you medication carefully and thoughtfully and me gatekeeping and not permitting you to have a hormone. There's a very careful difference here that I want to make. Running labs for me is understanding you. That's it. And caring for you. And looking at the labs and looking at you as that woman in front of me. I don't run labs to prove you wrong. I don't run labs to prove myself right. I run labs to understand you and to provide care. When you see some of these menopause specialists just blindly firing estrogen into women, I have valid concerns. Many menopause specialists have been doing this for just a few years. It's self-admitted, and I love them for that, to get into this space with me. But I've been doing it for 20. And so when I speak on these things, I promise you, I'm speaking from a place of experience. And if you watch my podcast, you'll see I'm not coming at it from a perspective of, I'm awesome, I'm a genius, you should all follow me. I don't think that way. That's not how my soul was built. That's not how I come to this place. I come to this place out of absolute care. That's it. So when the newer providers who are coming to this, becoming menopause specialists, use approaches that are not safe, in my experience, not just my opinion, in my experience, I'll speak to it. I don't just speak to it saying this is wrong. No, I say this is why I worry. If you're going to blind fire a hormone into a woman's body, how are you going to account for these things then? That's what I do. Because I don't believe in being condemning to another class of physicians. I don't believe that. I don't believe that's helpful to anyone. But I do believe in saying, this is how I got to my place of understanding. Do you have a different way of understanding it than I do? Can we somehow find what the better one is between the two of us and provide that to the woman in the room? That's it. That's it. Nothing fancy. That's it. So you'll notice I really do cite research, always. And I cite metabolic pathways that are well understood in medicine. So your physicians will know this. Some things we cannot, among the physicians, some things we cannot argue. Basic science is one of them. Basic physiology is one of them. We all have an understanding. We all have that similar language we share. So when I speak that language, I feel that I'm able to speak in a way that they will understand me, and they'll see that I'm not criticizing or condemning them, but I am challenging their approach, not because I want to point out who's smarter or better. I'm trying to seek safety and depth of care. Truly. That's it. There are a lot of people that have emotional charges around this because it has been so... Women, you have never been truly well treated by the medical industrial complex. When I give you these tools, I'm giving you scientific reasoning as to why you deserve better than what you're getting. That's it. That's it. So today, I'm thinking of that one woman, as I mentioned, who owned that store, who had menopause, abruptly sat at her doorstep because of a procedure that she felt was necessary, but her post-care was not great, leading to this 60-pound weight gain. It's just radical aging, emotional instability. She's such a lovely soul. She had a life. She had a beautiful husband that loved her. What else would we do other than do our best to help her? A person, every human being deserves 100% effort. Everyone. So this is my 100% effort for her. I'm thinking of her in this moment. When a woman goes through menopause, a hallmark of menopause is something called follicle stimulating hormone that becomes very elevated in menopause, postmenopausal. Let me step back for one moment. Let me walk you through it a little bit better. Every month, your body has a cycle and a rhythm. when you're pre-menopause, when you're just in your normal years of cycling. And a normal rhythm is going to be, run by something called FSH and LH. And FSH is from the pituitary, and that's the one that stimulates your ovaries to recruit follicles, and that starts the estrogen surge that occurs. And follicle stimulating hormone, those pushes from FSH into the ovaries, is what drives up how many eggs are recruited, and it's all there with fertility. Now, as you go into your perimenopausal years, what ends up happening is you start having diminished ovaries and you have diminished output. And so the brain senses that, and so it pushes a little bit harder with more FSH, hoping to get more ovarian output. So those higher level surges of FSH start to happen. You get a little more FSH, and then sometimes you get a real big return on that. You get a lot of ovarian return, so you have a high surge of estrogen. So that's why you see those women in the perimenopausal state get these big jumps in estrogen, right? And it came because there was a pull from that FSH from the pituitary saying, give me more. So it just pulls that, okay? The thing is we've always been thoughtful and focused on estrogen. And it's valid. It should be focused on and paid attention to. But that's not all that's going on. It's not just estrogen. Okay, estrogen is important, and those movements are very important. But FSH also plays a role separately. This is what I'm trying to discuss today. That's so important in here is to discuss the role FSH plays, because when you go to a provider, anyone, and they just either blind fire hormones into you, or say you don't need hormones, or anything that they say in there, they need to calculate for FSH as well. And I want to give you that information today. I want to be very specific with it. So FSH is that signal that comes from the pituitary to the ovary saying, I need more estrogen. And the lower your ovarian output is as you move through menopause, the higher the FSH goes. And most doctors only look at FSH in terms of the higher it goes, the more you're in menopause. And that's it. They think of it as a benign thing past that. It's not. It's not. It is not. Okay? FSH is not some just number on a sheet. It's your biology. And it plays a very important role in your health, which I'm going to get into now. The menopausal transition in women brings a lot of significant physiological changes. We see loss of bone density, and we also see increase in body fat, specifically central adiposity and visceral fat bumps up in that time. And we've always kind of thought of it in terms of estrogen, because estrogen does play a role in both of those things. So we've always been kind of just focused on there. FSH also plays a role in that as well. You see, FSH plays a role in weight gain because there are FSH receptors on your adipose. When FSH binds to those receptors, it does two things. One is it starts to slow down your metabolic rate. It affects something called cyclic AMP. Okay, so it's one of those things. So it slows down that thermogenesis of fat. It's the first step. The second thing it does is that when it binds that receptor, and the worst, my least favorite, is that it triggers your body to want to store fat a little bit more. So it upregulates adipocytes, storing of body fat. So FSH, again, slows down metabolism when it's high. And the other thing it does, it triggers your body to want to store fat. There's two negative things. The other thing it does in women is it triggers your body, it triggers osteoclasts in order for you to start breaking down bone density, because that's the other thing FSH binds to. Now, these receptors, you're supposed to have them. They're important. And I know estrogen plays a role also, because estrogen plays a role with body fat deposition, I know, and estrogen plays a role also with bone density. But FSH is in there. FSH is in there. There's enough studies that show with elevated FSH, you're going to have patients with storing of body fat, slowing down in metabolism. You're going to have an increase in white adipose instead of brown adipose, which is white adipose is the one that is not metabolically very active. Brown adipose is the kind that is metabolically active. Okay, so FSH plays a role in here. Further, as I mentioned, it plays a role with bone density. So we don't like FSH being supraphysiological for a cycle. We want to maintain that FSH with a certain range. So I always like my FSH to be down below 20 with my patients. It's very cautious. I'm very, very, very aware of this. 2/3 of people diagnosed with Alzheimer's disease are women. It just is. And there are a lot of really good books written on Alzheimer's. And my favorite is by Dr. Neil Bredesen. I always sing his praises. I think he's just a brilliant physician. I love his work. I really do admire him. I'm going to add my thing onto this. FSH plays a role. Studies show that elevated FSH increases amyloid beta peptide and tau proteins, which are what's associated with Alzheimer's progression. We also know that when you lower FSH, it reverses that, and that's been done in animal studies. So I'm not saying human studies, I'm saying animal studies very clearly on this, because I want you to know I'm not going to come on here and over tout the benefits of modulating FSH, but I will let you know these are the things that are implied by it and things that we should be aware of and thoughtful of, and we should be monitoring the research around that. A cross benefit for me prescribing hormone replacement therapy in my patients is that I get their FSH within the normal range and I monitor it. I don't let it stay wild. So the research supports me in that area for cognitive performance and cognitive health, and I stand by that. Further, FSH elevations are associated with emotional lability. Again, we always think, and that I post a lot on this, estrogen and progesterone are key to neurotransmitter synthesis and your neurobiology. When they cross the blood-brain barrier and turn into the neurosteroids that they do, which would be, pregnenolone, allopregnenolone from progesterone, testosterone turns into dihydrotestosterone also, but androstenediol. These neurosteroids play a role with emotional wellness, but so does FSH. Supraphysiological levels of FSH really do impact emotional stability as well. This rounded approach with my patients is what gives me the success I have. I'm not special. There's nothing about me that's special. I'm just like anybody else in the seat that I'm in right now, and I believe that. Anybody else sitting in the seat that I'm in right now, having the experience I have, would do the same thing I would do, would care the same way I do. It's just that I did it, so I'm here to share it. That's why I'm in the seat right now doing this. When you have a patient before you who has menopausal symptoms, just giving her a patch of estrogen is insufficient to me, because if you don't watch the FSH, did you fully bring it down? Did you just get some of it come down a little bit for symptom management, or did you really do your work and bring it all the way down? If you're not thinking of the woman as a whole human being, and you're just doing single shot, I'm just giving you this estrogen to stop your hot flashes, that's not respectful to you as a human being. If I go in that room with you and run my labs and think about you, really, really think about you, really sit down and think about our first appointment, all the things you told me, everything that you communicated with me, how you're feeling, what you've been going through, what your history is. And then I sit down and I order a lab work specific to all the things you brought up, areas where I think may be at play. And then I come back into the room with you. I say, these are the things I think that are going wrong. These are things I see going right as well, because you never want to tell someone everything's doing wrong. If I go in the room with you and tell you what I think could be helpful, and I'm going at you from a comprehensive approach, a holistic approach. I know that word's used a lot, but I'm using it, and this is the right term. Holistic is what's happening here. But I do that with you. How is that wrong? How is that gatekeeping? How is that inhibiting you from getting what you need? It's that kind of care you deserve, because as a human being, you have a long, beautiful life ahead of you. If this was that woman who owned that store that I'd met years ago when I was younger, with this much experience now, I look back and I say, well, her FSH was probably Richter super high from having that surgical menopause induced, surgically induced menopause. And that's valid. And I agree with the procedure, and many times it should be done. I get it. I understand the reason why. I'm not against that part. I'm against when we do things to women without looking at her as a whole human and where she's going to be 20 years from now, 30 years from now, 40 years from now. So FSH is not some random thing. it should be tested. It's further proof, I believe, that running labs on women before treating them and while treating them is essential to proper care, good care, caring care. I hope this helps. I truly do. My goal is to be helpful. To the degree that it is, I'm doing good. To the degree I'm not, let me know. I do care. Please send us a comment. I know I'm still looking mostly at Instagram for the comments. I'll get better at YouTube. I've been slowly getting better. I've just been busy. It's been a busy cycle here. My son just graduated high school, so it's been a lot of stuff going on. But things will start calming down pretty soon, hopefully, and I'll be able to get back on my normal schedule of things. But yeah, I will see you at the next episode. And thanks.